We are going to present a case of a DMEK, endothelial keratoplasty, unedited, so we can observe all the surgical steps in detail and see how to perform it in a simplified way. Here we have a case of a patient with Fuchs dystrophy, who had previously undergone cataract surgery with the implantation of a diffractive multifocal lens, as you can see here in the image. There is a very slight edema in the cornea. The guttae are present mainly throughout the central and peripheral areas, and there is no abnormality in the iris tissue. The position of the lens is correct. There is no vitreous, and there were no intraoperative complications during the cataract surgery. We are going to make a small paracentesis of 1.2 at the 10 o'clock position, and through this paracentesis we will introduce a cannula with cohesive viscoelastic. It is important to use cohesive viscoelastics, never dispersive ones, as dispersive viscoelastics will make it harder for the graft to adhere in the later stages of the surgery. With the pupil dilated, it also makes it easier for us to visualize the decimeter hexis, a maneuver that we are now starting at the periphery with a Sinski-Romo hook. We perform this maneuver over the full 360 degrees. Here we can see how we are easily detaching the Decimet's membrane. In these cases, visualization is good. It hasn't been necessary to remove the epithelium, which is sometimes essential to achieve proper visualization. We gradually try to gather the endothelium decimet tissue toward the central area, making sure not to damage the posterior stroma, not to tear excessively, but simply to drag the tissue. Carefully moving the tissue toward the central area. Next, using forceps. These are inverted John forceps. We gently pull downward and then outward, pulling softly so the tissue doesn't tear into several fragments. Here we are removing a small fragment of Decimet's membrane that hadn't been completely eliminated. And you can see that with these forceps, which are also blunt, they're specifically designed for this purpose. Specifically for this maneuver, we remove this small fragment of Decimet's membrane, which, if left behind, could have caused a possible detachment in the central area. We're going to irrigate with acetylcholine, which will contract the pupil. And in this way, we protect the lens and the from the subsequent maneuvers. So now we're going to ask the nurse to bring us a vitrectomy. Personally, I prefer to perform the peripheral iridectomy in the operating room, and we do it with a vitrectomy using a single-cut vitrectomy software and a suction setting of 350. Here we see, as we insert the vitrectomy, we move toward the 6 o'clock position, aspirate, press the pedal to position 3, and make the cut in a simple way. The presence of viscoelastic also helps us because if there is a small hemorrhage, it remains contained. In cases where there is more bleeding, it is necessary to place more viscoelastic in that area until the hemorrhage stops. Next, and with the viscoelastic, we are going to make a new paracentesis at the 2 side ports in a main incision with a 2.2 millimeter blade, but we are going to enlarge it to about 2.4 millimeters to make it easier for the injector we usually use in this technique to enter. Now we are going to ask the nurse to change the vitrector and to set up the irrigation aspiration cannula so we can remove the viscoelastic. I prefer to perform irrigation aspiration using the bimanual technique, with 1 irrigation cannula and 1 aspiration cannula. This way, we can reach every corner of the anterior chamber and completely remove the viscoelastic. Cohesive viscoelastics are generally easy to remove with aspiration and irrigation, and I have never had any issues with viscoelastic residue remaining in the anterior chamber. Once it has been removed, we proceed to insert the graft. We have prepared the graft beforehand. It comes preloaded, loaded in a Gouda glass injector, and under the microscope we check the correct orientation to try to insert it so that it comes out already properly oriented. With the left hand, we take the irrigation cannula connected to the pedal of the phacoemulsification machine, which we use to keep the chamber formed so that when we insert the injector, we can maintain the chamber. Then we remove it to avoid excessive pressurization and gently insert the graft into the anterior chamber. We try not to remove the injector too quickly to prevent it from coming out, since the scroll has been expelled, and we try to open it as it forms a bouquet. But we see that here it doesn't open completely, and we remove the injector and see that it has this almost 60-40 taco-like arrangement. Now, with two cannulas, we proceed to perform the external tapping maneuvers to try to open this graft. We are going to slightly deepen the anterior chamber to have a bit more space, which will make it easier to maneuver the graft inside it. As you can see here, we try to open this taco, positioning it, and as we drag it, we notice that the area around 2 and 3 o'clock starts to roll up, and as it rubs against the cornea, it begins to form a double roll. But we keep at it, and little by little, with our tapping maneuvers, we start to unfold it. We keep repositioning it toward the upper area. And now we will proceed with a check using microscope-adapted optical coherence tomography, or OCT. And with the OCT we are going to verify the correct orientation of the edges, which are rolled upward. Here we can see how the chamber is narrow, which really helps with these unfolding maneuvers. And with the OCT we always get visual confirmation of the correct orientation of this graft that we have placed. It really is a help. I don't think it's essential, but it's fantastic for those of us who regularly perform this technique. Let's continue and unfold the edges, which we had intentionally left a bit rolled up so we could see them with the OCT. We unfold them, center the graft properly, and then place an SF6 gas bubble. I prefer to use gas because it lasts longer. This allows us to position the patient during the first few days and helps the graft adhere, as well as keeping the rate of immediate postoperative complications low. We place a bubble, usually a 100% gas bubble, in the anterior chamber. The SF6 gas is prepared at a concentration of 20% with air. Here we are already removing it. We usually leave the patient for 10 minutes with the anterior chamber completely filled with gas. And then we reduce its size a bit until about 80% of the chamber is filled with gas. We position the patient for an hour and then send them home. At home, the patient again alternates positions. 2 hours lying on the right side, 2 hours on the left side, 2 hours on their back, and 2 hours free. And this 8-hour cycle is repeated for the first 3 or 4 days.